The emergency department was slammed the day that Vesta walked in. The putrid scent of disinfectant and sweat permeated that North Australian hot and humid heat. Bedridden patients banked back to back, bang, 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 bed block for the third time that week. Waiting room was at standing capacity only. I was the house officer on call for ophthalmology, and I was tired, I was hungry, and I wanted out. Packing up the last of my things to go home, I had chanced upon a conversation between an intern and her attending. So, she's a Norwegian backpacker, happens to be a med student actually. She's had conjunctivitis for a couple of weeks, but hasn't gotten better with the steroids that the GP had started. I was wondering if I could send her home with some endone, because she's in agony, and I thought oxycodone might do the trick. Oxycodone for conjunctivitis? Something wasn't right. Not that I was looking for more work at that time, but I politely interrupted and asked if I could look at the patient. Vision of 20/80, photophobic, injected, exquisitely sore, and the faintest of faint ring-shaped infiltrate in the center of her cornea. My heart sank. This was not conjunctivitis, this was acanthamoeba, and we were already 2 weeks late into the course. Acanthamoeba keratitis is a painful and potentially blinding disease. Rare though it may be, it is on the rise, and it is for this reason today that I'm going to teach you when exactly to rank acanthamoeba just that little bit higher on your differential list, how to detect and treat it early and start therapies and and your role in that prevention of Acanthamoeba keratitis. So Vesta went swimming in her contact lenses in a freshwater lake, the beautiful clear waters of Lake Mackenzie, Fraser Island, just off the east coast of Australia. 24 hours later, her left eye started to get a little bit watery, a little bit red, a little bit photophobic. Didn't think much of it at the time. The usual suspects run through your mind. Is this viral? Is this maybe bacterial? Less likely fungal? But I put it to you that if we knew a little bit more about Acanthamoeba and its pathophysiology, we'd know when to rank it higher on that list. So what is Acanthamoeba anyway? Apart from a really annoying diagnosis we have to remember at the bottom of our diagnosis list. 1, it's a single-celled protozoal organism which is freely living and is ubiquitous. It is found in water, soil, heating systems, aircon, storage systems, you name it, it's there. And I know that Canadians love to joke that literally everything in Australia is going to kill you or it's going to maim you, and for the most part, I probably wouldn't disagree. But at least this critter is one thing that Australia and Canada have in common. 2, Acanthamoeba exists in 2 forms, the trophozoite, which we can easily kill, and the cyst form, which is highly resistant to many forms of treatment. They can survive for over 23 years in the cyst state, surviving extremes of temperature, pH, desiccation, and chemical exposure. And thirdly, Acanthamoeba tends to attack the body in 3 ways. Keratitis, which we're all over, granulomatous encephalitis, and disseminated infection in our immunocompromised individuals. So if Acanthamoeba really is everywhere, why is it, and should we still be considering Acanthamoeba keratitis as a rare diagnosis? Well, I put it to you now that with the rise in contact lens wear, that boom in the last 20 to 30 years since the first case reports occurred in the 1970s, Acanthamoeba keratitis now accounts for 5% of all contact lens-related keratitis. And furthermore, 85% of Acanthamoeba keratitis occurs in contact lens wearers. But how did it even get in her eye anyway? Now remember, Vesta was a Norwegian backpacker, and it's not uncommon to see wicked camper vans, all sorts of rude graffiti on them, sliding up the east coast of Australia in particular. The thing is that limitations exist in terms of water access, and they commonly carry tanks of water that they use for drinking, cooking, cleaning, and of course, their contact lens wear. So that's just one source. The second source that we know already is that Vesta went swimming in a freshwater lake, which is a veritable soup of microorganisms. What happens is that when we've got our contact lenses on, the mechanical trauma combined with a hypoxic environment allows for direct inoculation of the cyst or the trophozoite into the corneal epithelium. Proteases are released, which lies through the corneal stroma, leading to scarring and perforation. And interestingly, Acanthamoeba loves to migrate along corneal nerves. They cause nerve destruction, which gives you an initial relative corneal anesthesia, and then the resultant inflammation gives you a radial keratoconjunctivitis, and that's where the intense pain comes from. So the first warning bells about that conversation, in fact, everything about that conversation between the intern and her attending was suspicious. So the first lesson today is to have a high index suspicion because you've taken a thorough history and examination, especially in the contact lens wearer with a history of contaminated water exposure and unresponsive infectious keratitis. So in the name of taking a thorough history, Vesta took us along a scenic route up the coast of East Australia. Starting off in Fraser Island, her conjunctivitis started there. She then drives her camper van up to the Capricorn coast. Eyes not better. Saw a number of GPs along the way. They started her on topical antihistamines. And she gets back into her van and she drives up the coast again to Mackay. Eye still not better. Started topical antibiotics. And she gets back into that camper van again and lands in the Whitsundays because you can't go to Australia without visiting the Whitsundays. And her eye's not better. And it's starting to get a little bit sore. And then they started topical steroids. And so she finally lands in Cairns on my doorstep of that emergency department that day. There is traditionally a long delay between the onset of symptoms and the diagnosis of acanthamoeba. And there are reasons for this are several-fold. Firstly, the clinical presentation is annoyingly obscure. They present with a vaguely red eye. They're a little bit photophobic. The pain out of proportion is often a late finding and sometimes isn't present at all. It's actually quite variable. And thirdly, the clinical presentation under the slit lamp mimics commonly herpetic disease and sometimes bacterial and sometimes fungal. So these patients are commonly misdiagnosed, started on inappropriate antimicrobial therapy, would then start on steroids because we think that they're sterile, partially alleviates the symptoms, they don't get referred, and that obscures the diagnosis. So how are we going to untangle our ways throughout that mess? The best advice that we can give to you is to take a corneal scraping for microscopy, culture and sensitivities, and send off an acanthamoebal PCR. Now, the microscopy can come back fairly quickly. These are actually the very photos taken from Vesta's eye of the cysts and trophozoites that we isolated. But I would put it to you that that's just pure dumb luck. It's not common that you're going to get that kind of result. And also it helps that she was literally a driving petri dish up that coast. Culture and sensitivities can take 2 weeks to come back. So it's really important that we get onto the lab and make sure that they're checking those plates every day. And thirdly, with the acanthamoebal PCR, you can have that cooking in the background, and sometimes that's the only thing that you've got to hang your hat on. Now, not only is diagnosis a pain, but so is the treatment. And it is absolutely crucial that we explain to our patients that the treatment is long and intense. Because the cysts are so resistant to several forms of therapy, and that's why we need to treat them for that long. Initially, intensively on hourly drops, and then gradually petering out. In Vesta's case, we started her on triple therapy. So chlorhexidine, polyhexamethylbiguanide, and Brolene. Although 2 agents, ideally 1 from each class, would suffice. Patients need to be educated that even after that initial 12 months, once their eye is quiet and uninflamed and their vision's back, that these patients, if they're bad, may go on to need corneal transplantation. Or secondly, if their eye gets sore, if their vision gets worse, they need to come back, and we as clinicians need to have a low threshold to recommence anti-amoebic therapy. So the second lesson today is AK is a pain in the proverbial to diagnose, a pain in the proverbial to treat, but early treatment and diagnosis prevents significant visual morbidity. Hygiene, hygiene, hygiene. You will remember that Vesta was a backpacker, And so we had the chance, because we were intrigued by the fact that she was a backpacker and limited access to water, that was an easy case. But probably we as clinicians don't spend that amount of time interrogating our patients who are contact lens wearers about how it is that they treat their contacts. Not uncommonly, we think of things like sleeping in them, stretching dailies to weeklies, weeklies to monthlies, but asking targeted questions. Do you spend time in a hot tub in your contact lenses? Do you do your water sports in contact lenses? Do you sneak a little bit of water into your contact lens case because you think you're either trying to save money or maybe you're a little bit lazy? Who knows? But we need to ask a little bit of targeted questions, particularly in these cases. Now, the practice of the top-off is something that should be in particular in the front of your mind when you're thinking about acanthamoeba. In a recent CDC study, the practice of the top-off was associated with a 4-fold increase in the rate of Acanthamoeba keratitis. But what is this top-off? So the top-off is literally you have your contact lens case, you have your old contact lens solution inside, and you're just topping off with fresh contact lens solution because you're either cheap or because you're lazy or for whatever reason. It's really important that we use the opportunity to teach our patients not to do that, because effectively that contact lens case remains moist and a biofilm develops. And if you've been using contaminated water, who knows how long those cysts are going to stay in that contact lens case. So lesson 3, poor contact lens hygiene and contaminated water exposure is your single biggest risk factor for the development of AK. It was pure luck that Vesta walked into the emergency department that day. Chance that I hadn't left, serendipity perhaps that that conversation was even overheard. She could very well have been sent up further up the east coast of Australia, pain masked on painkillers, on steroids, and eventually have lost her eye. Instead, I hope I've proven to you today the importance of when to consider acanthamoeba higher on your diagnosis list, how to diagnose and treat it as early as you can, and the importance of our role in preventing acanthamoeba keratitis patients. Vesta now practices as an obstetrician in Norway, vision of 2030, 6 years down the track. I hope that you're as lucky in catching your Vesta too.